I've just washed my hands after entering the patient's room. Hi, my name's Erin, and I'm a D&T candidate from Palm Beach Atlantic University, and I'm going to be doing your head-to-toe assessment today.
Okay.
Okay?
Mm-hmm.
Nice to meet you. What's your name?
David.
Alright, so I'm going to start by assessing his head and scalp. I am starting by assessing his hair for the color, for the cleanliness, for the texture, if it's thick, if it's thin, if it's coarse, if it's fine, if it's clean, if it has good distribution, or if he has areas of baldness. And if he does have areas of baldness, which he doesn't, then I'm going to note the pattern of baldness. Then I'm going to palpate. I'm going to palpate for any masses, any nodules, any tenderness. Also noting that there are no nits, there's no scales or lesions, bumps, bruises, hematomas, anything of the like. Was there any pain when I palpated your head?
No.
No? Okay, good. So I've palpated and assessed his head for size and symmetry, and I have determined that it is atraumatic and normocephalic. Okay, now I'm going to be assessing his face for any edema, masses, lesions, symmetry, contour, facial expression. He doesn't have a flat affect, so that's good. Now close your eyes. I'm going to palpate your lacrimal glands. Tell me if this is tender at all.
No.
Okay, and then I'm going to palpate your sinuses. Tell me if that's tender.
No.
No?
No.
Okay, good. All right, now I'm going to be assessing his facial nerve. Can you raise your eyebrows? Okay, puff out your cheeks. Let me pull the air out. Close your eyes really tight, so let me open them. Okay, very good. All right, now I'm going to be assessing the trigeminal motor function. Can you clench your jaw? Feeling the temporal and the mandibular. Try to move your jaw back and forth. Good job. Okay. Now I'm going to be assessing the sensory function of the trigeminal nerve. So I'm going to have you close your eyes and tell me which side of the face I'm touching.
Left. Right. Left. Right.
Good. Okay, I'm assessing the eyebrows for quality, for any infestation, for any scaling, any lesions, edema, or any lateral sparseness. Okay, now I'm checking the eyes, I'm checking the lids, I'm checking for any lid lag, any ptosis, symmetry of the irises, symmetry of the color, any lesions, any exudates, growths, styes, exophthalmos, and for symmetry of the palpebral fissures. That is checking the cranial nerve 3. I'm checking the eyelashes for the color, for the condition, for any infestations, for their direction, any entropion or ectropion. Alright, now I'm assessing the lacrimal puncta and the conjunctiva. Pull your eyelid down for any redness, any excessive tearing, swelling, discharge, lesions, or exudates. Now I'm checking the sclera, make sure that's white bilaterally, doesn't have any lesions, any drainage, it's not white,
Yellow,
blue, or red. Turn your head a little bit, I'm checking the corneas for any cloudiness, any scratches, any lesions, any ulcerations. Now I'm also looking at the irises, I'm checking their color for symmetrical shape, symmetrical size, and for shadows. Now I'm also checking the pupils for their symmetrical size and shape. We're going to test the visual fields by confrontation, so I'm going to have you cover one eye, and I'm going to cover the same eye, and then we're testing your peripheral vision. Tell me when you see my hand.
No. 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 No.
Okay. Cover the other eye.
No. 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 No.
Okay. We're going to do the cover-uncover test, where I'm going to cover your left eye, and I'm observing the right eye for any movement or any drifting of the eye. Okay. Same with the right eye. Good. We're going to do near-far reaction accommodation. Focus on my finger, and then focus on the wall behind me. On my finger, on the wall behind me. Good. Alright, so now we're testing the corneal reflex. Make sure that the reflection is in the same spot in both of his eyes. And now we're testing the pupillary reaction to light for it to be direct and consensual. Good. Now I'm going to have you follow my finger with just your eyes. I'm testing convergence. Good. Alright, now we're going to do the fundoscope exam. I'm going to pretend that this is an ophthalmic scope. So I'm going to do my right eye to the patient's right eye. Hold his head, have him look straight forward, and come in at an angle. Coming in, the whole time I'm looking for the red light reflex, which he has. I'm looking for the background to look for the arteries, make sure they're smaller and lighter. For the physiologic cup, for cup to disc ratio, and to make sure that the cup has good, crisp margins. I'm going to do it on this side. I'm also looking for the optic disc and for any hemorrhages, lesions, or exudates. So now I'm inspecting the ears. I am making sure that they are symmetrical on both sides. I'm inspecting the auricles, the pinna, no lesions, deformities, bumps, masses. Doing the tug test. Any pain?
No.
Also pressing on the mastoid
Now we're
bone
going
and the
to
tragus for any pain or
conduct
tenderness.
the auditory test. So I'm going to have him plug his left ear. For the sake of our setup, he's going to turn and repeat what I say.
Purple. Baseball. 2.
Okay. And then turn, plug your right ear.
Apple. Lemon. 0.
Okay. Continuing the auditory test, I'm going to conduct the Weber test. Tell me if you hear it in both ears.
Yes.
Okay. Tell me when you stop hearing it.
This is the Rene test.
This is considered bone conduction. It's on the mastoid bone behind his ear. Mr. David has good hearing.
I don't hear it anymore.
You hear it now?
Yes.
Tell me when you stop hearing it. And this is good because air conduction is meant to be longer than bone conduction.
I don't hear it anymore.
Same thing on this side. It's an otoscope for this examination purposes. Tilt your head, please. So for adults 12 and older, you'll pull the pinna up and back. For 12 and younger, you'll pull it down and back. So I am examining his ear canal. I'm looking for any lesions, exudates, earwax, foreign bodies, growths, or abnormalities. Going into the ear canal, I'm looking for a pearly gray tympanic membrane. I'm looking for the light reflex. You have to kind of tilt it towards the patient's nose to get a good look at it. I'm looking for any exudates, any growths, any lesions, any changing colors, any perforations, tubes, crusting, foreign bodies, the short handle of the malleolus, the handle of the malleolus, the short process, any bulging retractions or exudates. And we'll continue this on the other side. Okay. Now we're going to be assessing David's nose. I'm looking at it straight on to make sure that it is symmetrical. He doesn't have a deviated septum. It's not crooked. It doesn't look like he had a broken nose in his life. Looking for any excessive hair, crusting, lesions, drainage. Turning his chin up, I'm going to be looking at his turbidates. They're pink and moist. They're not blue or pale or boggy. He doesn't have any excessive hair, drainage, or foreign bodies up in his nose. His nose looks patent. He can get air in and out. Turn your chin down. Close your eyes. Please tell me what you smell.
Alcohol.
Good. I'm checking his nasal mucosa for any swelling, bleeding, perforations, polyps, or lesions. And also making sure that his septum doesn't have any deviation swelling or perforation. Okay. Starting with the observation of the mouth, we're going to be noting his breath, if it has any odors to it, which it does not. Now we're going to be examining David's lips and mouth for symmetry. They have good color. They don't have any lesions or irregular borders, masses or growths. I have my baby joining us. Now please open your mouth. Stick out your tongue. Say ah. And so I'm assessing his soft palate and his hard palate. For his tongue, can you move it back and forth? Okay, good. Now I'm going to be using a tool, stick out your tongue, to move his tongue over so I can look at his buccal mucosa, down at his gums. Okay? Yeah, open your mouth a little bit wider. Move it to the right. Assessing this buccal mucosa, and some normal findings are a white bite line on the inside of their cheek. I'm assessing for the Stetson's ducts, which are on the upper, by the second back molar, and then the Wharton's ducts, which are in the lower. Can you tilt your chin down? Lift up your tongue. On the inside, underneath the tongue, bilaterally. I'm going to have you stick out your tongue and say ah again. I'm going to check you for a gag reflex, okay? Okay. Good, rise and fall of the uvula. Can you stick out your tongue and say ah again? Say ah. Looking for the tonsils. I don't see any tonsillar enlargement. Like I said, no discoloration of the soft or hard palate. The tongue has good texture, color, symmetry, border. It's not white, black, or anything else. I'm checking the oral mucosa for any colors, white patches, nodules, or lesions. I'm checking the gums for color, pink color, any swelling, any retractions, any hypertrophy, bleeding, or lesions. I'm checking his teeth. I'm looking for any fillings, for the color, for any caries, for any loose teeth, broken teeth, rotting teeth, fillings. Okay, I'm going to be assessing David's neck. I'm looking for symmetry, for any scars, for any masses, any enlarged lymph nodes. Everything looks good. I'm going to be assessing his sternomastoid muscles. Push up on my hands with your shoulders. Okay. I'm going to be assessing his trapezius muscles. Turn into my hand. Keep turning. Okay. Same on this side. Alright. Now I'm going to be assessing his trachea. Sit up straight. I'm going to make sure it's midline. It's not deviated to the right or to the left. I'm looking at his thyroid also. I'm looking for its shape, for its size, its symmetry, texture. Now I'm going to be having David take a sip of water while I palpate it from behind.
With a purple cup.
Alright. Can you take a drink of water, please? Very good. Do it again. One more time. Okay. Now I'm going to be assessing his lymph nodes, and there are many of them. So these are the posterior auricle, the pre-auricle, the tonsillar, the submandibular, tilt your chin down. Submental, occipital, none of them are palpable, which is a good thing. The superior clavicular, subclavicular,
infraclavicular,
up for me. Now we're assessing the axillary lymph nodes, the central, lateral, pectoral, and the subscapular. None of them are palpable. It's a good thing. Now I'm going to palpate the carotid pulses one at a time. You don't want to choke your patient or cut off blood flow to the head. Now I'm going to auscultate the carotid pulses and the thyroid for bruits. First the thyroid. Can you take a deep breath and hold it? Good. And you should auscultate nothing. You should hear nothing. I'm assessing his skin. I'm assessing for the pigmentation, for the color, the any redness, jaundice, pallor, for any lesions. If I do see any lesions, then I'm going to note their color, shape, border, size, and symmetry, making sure that his pigmentation is the same throughout. I'm also noting hair distribution, lack of hair, moisture, whether it's dry, whether it's clammy, the temperature is warm, dry, pale, or cool, or diaphoretic. We're looking for any localized warmth. We're looking for motility, for any tenting, so we're going to pinch. Make sure that it goes back immediately, doesn't stay tented. And for the texture, whether it's rough, whether it's smooth. Now we're looking at his nails. We're looking for the color, the shape, the size, any jagged edges. We're looking for cap refill, making sure that it's under 3 seconds, making sure that his nail beds are pink, not blue or white. Looking for clubbing, any swelling, growths, lesions. Growths or lesions. Looking for any ankylosis or filling or hangnails, fungal infections, anything of the sort. Okay. We're also going to be looking for any joint tenderness or abnormalities. We're going to be looking at Bouchard's, which is this first proximal joint, proximal to the hand, for any swelling or tenderness or deformities. If a patient has RA, then they have a pretty typical sign where their finger, their joint would be pointing to the ulnar side of the hand, just at that joint. That's the Bouchard's joint. And then the Erberden's joint is distal to the hand. And for any swelling or nodule enlargement, that's usually indicative of osteoarthritis. We're going to continue with the examination of the thorax. So I'm looking at his skin. I am looking for his AP diameter. It should be a 2-to-1 diameter, where his AP to lateral, where his depth should be 1/2 of his width. In patients that have COPD, you'll see what's called barrel-chested, where their ratio is 1-to-1, where it's all the same. So then we're going to continue with auscultation. I'm listening for bronchiovesicular breath sounds. Take a deep breath. Vesicular breath sounds, which are the bases. Bronchial breath sounds. and tracheal breath sounds. Okay. Now breathe normally. Also, prior to auscultating, you would note his resting respiratory status, the depth of his respirations, the rate, the rhythm, how hard he's working to breathe, if you see any kind of sternal retractions, which would indicate that he's in respiratory distress. Moving on, we're going to be listening to the heart sounds. With the diaphragm, I'm listening to the aortic. Breathe normally. Pulmonic. Herb's point. Tricuspid. Mitral. If I had a bell, I would flip it over. Listen again, all the way up. Then I'm going to have the patient lean forward. I'm listening along the left sternal border and at the apex for any aortic regurgitations. I'm also listening for a displaced apex, would it indicate cardiac enlargement. Okay, lean back. Thank you. Doing that, we're listening for any adventitious lung sounds such as crackles, wheezes, bronchi, or stridor. When listening to heart sounds, we are listening for any adventitious heart sounds such as murmurs, gallops, rubs, or S3 or S4 heart sounds. Moving on to palpation. We're going to be palpating for any crepitus, which would indicate air in the subcutaneous tissue, or any areas of tenderness. How are you?
Good.
Good. Okay. After auscultating, we're going to continue with tactile ephemeris. Please say 99.
99. 99. 99.
And then we're going to continue with percussion. You're going to use your dominant hand, the middle finger, to strike the middle finger of your non-dominant hand. We are listening for resonance. I'll say it a little louder. We're listening for resonance. Okay. Moving on to the posterior of the thorax, we're going to start with inspection. We're looking at his skin, making sure that there's no scars or lesions or any abnormal moles. If we see any, we're going to note their color, their symmetry, their border, their size, their shape. I don't see anything on him, so that's good. It's warm, pink, dry. We're going to move on with auscultating. Deep breath. Now I'm going to move on to egophony, so I'm going to have him say the letter E and hold it while I listen. I should not hear the sound A. That would be listening. That would be noting consolidation in his lungs. So when you feel my stethoscope, please say E and hold it. Okay. Now we're going to be testing bronchophony, where I'm going to have him say 99 when my stethoscope touches his back.
99. 99. 99. 99. 99. 99. 99. 99.
Now a kind of another version of bronchophony is whispered pectoriloquy, where I'm going to have him whisper 99, and if I then hear it, then that is usually also indicative of consolidation. I should not be able to hear him whispering 99. Now I'm assessing the spinal curvature. I want to make sure that the cervical, lumbar, and thoracic are what they should be. I'm assessing for spinal tenderness. Can you tell me if that feels tender at all?
No.
Okay. And then I'm going to assess for symmetrical symmetry of his chest expansion. Take a deep breath. Good. My hands moved equally. We're going to continue with tactile fremitus. Say 99.
99, 99, 99, 99,
And percussion. Okay. And then I'm going to assess for CVA tenderness, which is normally in patients who are experiencing a kidney stone. It's good that David doesn't have any. Right. If David was in fact a woman, we would continue with the breast exam. So I would have him raise his arms above his head, lower them at his side. I'd be inspecting for any changes. I want to see symmetry. I'm assessing for the contour, for any dimpling, peau d'orange, or inverted nipples. I would have David hold his hands at his hips and go forward like that. I don't want to see any changes in the breasts in that position. Okay, lean back. Thank you. I would also complete this I would palpate for any tenderness. There are many different ways to palpate a woman's breast, but you could do it in a circular fashion, up and down fashion, or in a kind of a star-like fashion. And you would always want to include the axillary lymph node in that palpation for any tenderness, any nodules, any bumps, any masses. Continuing the breast exam, we would be actually in a supine position, which we don't have at this moment, but he would be lying flat, and I would again assess the breast on a woman for the contour, for the symmetry, for any inverted nippling or any nipple discharge, tenderness, nodules, masses, swelling, or tenderness. So we would do one side, including the lymph node, and then the other, the lymph node, and pinch the nipple after each exam. Now we are assessing for his JVP, which is jugulus venous pressure, pulsations, and we're going to be measuring his JVP as well. So please turn your head to the side. You want them at a 45-degree angle. In normal, healthy individuals, you will usually not see the JVP because, and this is different from the carotid artery. The carotid is up here, and then the JVP. If you saw a pulsation, that would indicate a high JVP, which is an abnormal finding. Turn towards me. So you're seeing the sternocleidomastoid muscle right there, and you'll normally see the JVP right alongside of it. Turn to face the camera. To measure the JVP, you would have two straight edges, with one of them being a ruler. So having the patient lie at a 45-degree angle and having a straight edge coming directly out from this angle, you would then measure wherever you see the JVP, which we don't see it, so this is the lowest point. And then you would measure with a ruler the angle coming straight up from their chest. If I had a ruler, this would probably be about 3 to 4 centimeters, which is a normal finding. Now we're going to be assessing the abdomen. We start with inspection. We're looking at the skin for any rashes, scars, striae, or any abnormalities. We are also inspecting the abdomen itself for any asymmetry, for any bulges, any peristalsis, any distension. We want to make sure that they're nice and flat. And then we're going to be assessing the umbilicus for any hernias, for the contour, the shape, any bulges there as well. Now we're going to auscultate the abdomen, which follows inspection. We're listening to his vowel sounds in all 4 quadrants. He has very good vowel sounds. If you do not hear any, you must listen in each quadrant for 1 minute before you can document that there are absent vowel sounds. We're also going to be listening for any venous hums over the arteries, the descending aorta. We're listening for any bruits, and for any friction rubs. I'm following auscultation with percussion and palpation. I'm going to percuss the abdomen in all 4 quadrants. We're testing for tympany, listening for tympany. Now I'm going to percuss the liver span down the right midclavicular line. And I'm going to percuss and palpate the spleen. Take a deep breath. Take a deep breath again. The spleen is normally not palpable because it is covered by the left-sided ribcage. His is not. I'm going to palpate the liver. Take a deep breath. Do it again. Sorry. In those of more musculature, it is a little more difficult to palpate the liver, but you should feel it just tapping your fingertips underneath the right-sided ribcage, yeah. We're going to continue with palpating the abdomen, first with light palpation. And if they have any tenderness with that, then you'll know where not to continue with deep palpation. If there is no tenderness, then you'll continue with deep palpation. Okay. And then we're assessing for palpating for any aortic pulsations. Now we're going to assess for some signs of peritoneal irritation and for appendicitis and cholecystitis. So a few of those are Murphy's sign. If you feel right in this right upper quadrant, you press down and they have pain, then that is usually indicative of cholecystitis. And then McBurney's sign, if you find the ASIS, the anterior superior iliac spine, and then halfway between that and the umbilicus is McBurney's point, where if you press that down and they have pain and tenderness, then that usually is indicative of appendicitis. Rebound tenderness is also indicative of appendicitis, where when you push in and you quickly release, you ask them what hurt more, the initial pushing in or when you released your hand. With Murphy's sign, if they have inspiratory arrest, when you're pushing down, you have them take a deep breath, and if they stop taking that deep breath because of the pain, that's what's indicative of cholecystitis. Rostving's sign is when you press down on the right side and they feel pain on the left side. That is also indicative
on the left
of
and
appendicitis.
pain on the right.
Iliopsoas sign is I'm going to have you kind of bend your knee, push up against my hand. Okay? And this one. If that causes pain in the abdomen, that's also indicative of appendicitis. Obturator sign is when you internally rotate the knee and then externally rotate the knee. assessing for pain in the abdomen. I'm not going to do this on Mr. David, but in a normal exam, you would also pull down their pants or move the drape to the side so you can assess, auscultate, and palpate their inguinal nodes and their femoral arteries. He's going to demonstrate hip extension. Raise one leg straight up. Good. And the other one. Okay, flip over for me. You could also do this standing up, but for a lot of patients in the hospital, they're going to be in bed. This will be easier for them that way. Now we're going to do hip flexion. Raise your leg straight up. Good. And the other one. Okay. I'm going to have you bend your knees. Bend. And extend. Okay. Now lay them flat. Now lift this one up. Don't bend the knee. And can you cross it over your other one? Lift it up and cross it over. There you go. That's adduction. And then push it out. Abduction. And the other one. Abduction and adduction.
As well as internal and
Exaggerated,
external
but-
Gets the
rotation.
job done. Now I'm going to palpate his joints for any tenderness, any crepitus. Do they hurt? Mobility. Have you sit up? And then his back. Alright, lie down. Now I'm going to have David do the straight leg raise, and this is checking for pain, radiculopathy in his lumbosacral area. Raise your leg straight up. Do you have any pain?
No.
Good. This one?
No.
Good. Okay. Now I'm going to be testing for Kiernick's sign, which is a meningeal test. I'm going to be bending his hip and his knee both at 90 degrees, and I'm going to be slowly extending his leg. And if this causes his head to raise up, that is his attempt at reducing the pain that this is causing, and that's a positive meningeal sign. Now we're going to do Brudzinski's test, where David is going to touch his chin to his neck, and if that causes pain, then he's going to be bending his knees in an attempt to decrease that pain, and that is another positive meningeal sign. Now I'm going to have David demonstrate tandem walking, which is heel to toe in one direction, and then turn around, and then the other.
I should also have had David walk on his toes and then walk on his heels.
Now I'm going to have David demonstrate hopping on one foot in one place, and then the other. Now he's going to demonstrate a shallow knee bend. Now I'm going to stand next to him as I have him do the Romberg. Close your eyes. Just keep him closed. I'm going to see if he sways or loses his balance. Open him. And then I'm going to have him demonstrate the pronator drift. We're going to hold your hands out in front of you and close your eyes. Palms up. Pronator drift assesses for at least 10 seconds, and it's watching to see if he slowly turns one hand inward, which would indicate some kind of neurological damage. Okay. Now we're going to do the Adam's bend, where we're going to have him bend forward. All the way. Put your chin down. I'm assessing for scoliosis of the spine. Okay. I'm going to have David demonstrate range of motion of his neck. So can you turn and look over one shoulder, and then the other? And then while looking forward, bend your head side to side. And look back. And look down. Any pain?
Nope.
Good. We're going to be having David demonstrate range of motion of his back. We're going to have him flex and extend. So when you flex, come towards me. Bend at the waist. And extend. See how far you can go back. Okay, good. Now turn and face the camera, please. I'm going to have you bend side to side. And then rotate. Now we're going to be demonstrating range of motion of the upper body. So please flex your shoulders and extend. The other one. And then I'm going to have you perform abduction or adduction, which is crossing in front of you, and abduction, which is going away. Okay. Now I'm going to have you demonstrate range of motion of your elbow, flexion, extension, and the other one. Then I'm going to have you rotate, supinate, and pronate. Good. It's good range of motion there. And then with your wrists, we're going to have you flex and extend. And then can you move them back and forth? Good. And then with your fingers, and your thumbs. Your fingers flex and extend. Okay. We're going to continue with our assessment of the lower extremities. First, you want to note the skin, the color, the warmth, the texture, if there's good hair distribution. You're also looking to see if the skin is shiny and taut with no hair growth. That's usually an indicator of poor circulation. You're looking for any edema. You're going to palpate for edema on the dorsum of the foot. You're going to note its grade from 1 to 4, 1 being not very pitting and 4 being very pitting. You're going to look at the back of the leg, around the ankle, and then up the shin is where you're going to look for edema. And we're going to be checking his toenails, color for ridging, swelling, fungus, growths, lesions, scars, masses, for good cap refill. Beautiful. We're going to be checking the pulses on the dorsalis pedis. Very good pulses. Also the posterior tibialis on the inside of the foot. The posterior tibialis on the medial side of the ankle. The the popliteal, which is pretty difficult to palpate. You want to have your fingers meet in the middle and then come out from there. And then we already assessed the femoral pulses when he was in the supine position. You want to do this bilaterally on both legs. We also are looking at the bony prominences, especially on the elderly patient. You want to look at the underside of the heel, make sure that there's no ulcerations, and over the ankles especially. And over the ankles especially. I'm going to be testing David's knee range of motion. So, he's already in the flex position. We're going to have him extend. And flex. And then extend. And then do dorsiflexion. Pull your toes up towards your nose. And then plantar flexion. Put your toes downward. Same on this side. Pull your toes up. Push them down. And then ankle range of motion. You move it side to side and all around. Both of them. Now we're going to be testing David's strength. So turn into my hand. Turn into my hand. Bend your head into my hand. On the other side. Push your forehead forward into my hand. And back. Push your shoulders up. Good. Put your hands out like this. Don't let me push them down. Put your arms straight out. Don't let me push them down. Don't let me push them up. Push out. Push in. Good. Grip my fingers. Squeeze and let go. Okay. Try to pull me towards you. Push me away. Very good. Try to bend your wrists up and down. Good. Spread. Bend your wrists up and down. Very good. Spread your fingers out. Don't let me push them in. Very good. Keep your thumb out. Push it towards me. Push it towards me. Very good. Now, relax your knees. Relax your posture. Push out and in. Push this one up. You raise it up and push it down. Push it down. Push it up and down. Push your legs out towards me. Your shins out towards me. Towards me. Very good. Pull them towards you. Push them out. In. Okay. Push your toes up. Down. Out. And in. Fly your toes. Don't let me push them in. Good. We're doing some deep tendon reflexes. This is the tricep, which is going to test for innervation of C6 and C7. You have to have their arm and shoulder completely relaxed. Now we're going to do the bicep. You have to have their arm completely relaxed in their leg, and it's testing for innervation of C5 and C6. Now we're going to do brachioradialis, which is we're going to watch for their thumb in this case, and it's testing for innervation of C5 and C6. Now I'm going to be doing the patella, which is testing for innervation of L2, 3, and 4. Okay, now I'm going to be doing plantar and ankle. So I'm going to dorsiflex this foot and hit the Achilles, and I'm looking for plantar flexion. And looking for innervation of L5 and S1. We're going to start with the neurological examination. So I am observing David's face, his facial expression, whether he has a flat affect or if he's expressive towards things that I say to him. I'm also going to ask him, what's your name?
David.
What's your date of birth?
12/02/1990.
Okay. Do you know what year it is?
It is 2016.
Do you know who the president is?
President Barack Obama.
Very good. So we have established that he is alert. He's looking at me and he's oriented to time, place, person, and situation. Okay, so I'm going to have him demonstrate the ability to rapidly alternate his hands on his thighs. Can you do that for me?
Can you make him down a little bit?
Now, can you demonstrate tapping the pads of your index finger with your thumb rapidly? Very good. So looking straight at me, I'm going to have you touch your finger to your nose and then touch my finger. Very good. With your eyes closed, when I touch you, tell me that if it's dull or soft. Okay?
Dull. Soft. Dull. Soft. Dull. Soft.
Very good. Now we're going to be testing the vibratory senses of David's fingers and toes. So close your eyes. Raise your fingers. Do you feel this?
Yes.
What does it feel like?
Feels like buzzing. Or
Feel it?
vibrating.
Do you feel it now?
No.
Now?
Yes.
Do you feel it now?
Yes. No.
Okay. Now I'm going to do it on his toes. It'd be easier if he was actually on an exam table, but he's not. Close your eyes. Do you feel this?
Yes.
Do you feel
yes.
it now?
No.
No?
Yes.
Other foot. You feel it now?
Yes.
No?
No.
Now we're going to test his proprioception. So can you hold out your fingers for me? Close your eyes. Tell me if I'm pointing your finger up or down.
Up. Down. Up. Up. Down.
Okay? And your toes, please. Close your eyes.
Up. Down. 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 Up.
Okay. Now we're going to test stereognosis. Can you hold out your hand? Close your eyes. Can you identify the object in your hand?
A nipple.
Open your hand. Keep your eyes closed. Identify this object.
A safety pin. I mean a clothespin. Paperclip.
Paperclip.
That's what I meant.
There we go. We're testing graphesthesia, so I'm going to draw a number in your hand and tell me what number it is.
A 3.
Okay, now I'm going to draw a letter in the other hand. Tell me what it is.
An A.
I'm going to have him tap my hand with the ball of his foot. And the other one?
They can't see it.
Okay. I'm going to have David demonstrate the heel to shin test. With his eyes open and then with them closed. Close your eyes. People suffering a stroke have a very difficult time with this on the side that they're suffering on. And that's all. Thanks for watching. Okay. Hi, my name is Erin and I am a DNP candidate at Palm Beach Athletic University. You can't laugh!
Okay.
Don't play with my tools.
I wish you would talk to a patient like that. Smack these babies.
Can you raise your eyebrows? Raise your eyebrows. There you go. Okay. Squid squeal.
Squid squeal.
This is your fault.
Raise your eyebrows. Don't just open your eyes wider. Raise your eyebrows.
Sorry, symmetry. Good facial expression. Everything. Can't say everything works out. Contour, symmetry, edema, masses, lesions, hair distribution, and color.
Nailed it. Alright, I got myself.
Oh, sorry.
This is not sponsored by Angry Orchard Apple Cider. Mother.
So we're going to.
Nose inspection.
This is my boyfriend, you guys. Okay, to the right.
I think so. I don't know, you're the nurse practitioner.
Now I'm going to be assessing his. What's it called? When you are auscultating for vesicular breath sounds, they. Now, can you tell me, with your eyes closed, whether what you feel is soft or dull? Close your eyes.
Soft.
I meant to use this for the soft as well.
What the fuck? You're making me feel like I'm failing the test.
Alright. Take 5.
Ugh.
6 or 7 or 8, whatever this is. Now I'm going to be assessing the vibration of his fingers. I'm going to draw a number in your hand with your eyes closed. You're going to tell me what number it is, okay?
8. 3. Come on, how similar are those?
We're going to test graphesthesia. I'm going to draw something in your hand. You're going to tell me the letter.
4. What was it?
What an A.
Did you say a letter?
Yeah.
Oh, I thought you said... Now we're getting Tell me what letter I'm drawing.
Wow.
4. I thought we were still doing the number thing.
No,
4.
For the means of this exam, for adults and children 12 years and older, we're going to pull the pinna up and back. For children 12 years and younger, you would pull the...
What is this thing? How does this thing
I'm
work?
trying to figure out.
How does this
That is
work?
the pinna. I'm not. No, that's the pinna. The oracle? No, that's the pinna. This is the oracle.
You are arguing with your...